apply these principles which I'm going to discuss with you now. And in fact, every scan that I do examining the heart, I do the same way. So when you look at cardiac abnormalities, before I start, it's important to have some idea in your head to break it down into categories. So in my head, I have abnormalities of the left heart, abnormalities of the right heart, abnormalities of the crossover of the great vessels, abnormalities of the septum, and the spatial arrangement anomalies, transposition and correct transposition, and then the venous anomalies. That's 1, 2, 3, 4, 5, 6 main categories. And it's important for you to understand when you go through each section as to what abnormality you expect to see. And I have given that information in the cardiac handbook. So when you do a cardiac examination, according to the SIêU guidelines, we look at the section number 1 at the level of the stomach. And when you look at the stomach, it is on the left-hand side. You then see the intrahepatic vein, which sweeps away through the stomach. It is like the letter J, it sweeps in and away. And then on the opposite side is the fecal gallbladder. And the aorta is on the left-hand side of the screen, and the IVC is anterior and to the right. So for every cardiac examination that I do, I look at these structures. Confirmed, stomach's on the left, 1. Descending aorta left, spine, 2. IVC anterior to the right, 3. Intrahepatic veins sweeping away from the stomach, 4. Gallbladder on the right, 5. So the heart doesn't start with examining the heart, it starts with examining the abdomen. The next is section number 2. And section number 2 is the evaluation of the 4-chamber view of the heart. I look at the size of the left and the right atrium. I look at the size of the left and the right ventricle, ensuring that there is symmetry. I make sure that I can see the pulmonary veins entering into the left atrium. And you need to understand how to examine the pulmonary veins using slow flow balance and using power Doppler. And I will show you this. In examining this, I look at the interventricular septum, I look at the atrioventricular valve, and I look at the atrium primum. The next stage after doing section 2 of the heart is section 3, the 5-chamber. And looking at the 5-chamber view of the heart, I look at the aorta as it leaves the left ventricle. There are 3 things that I'm looking for, well, 5 things actually. But number 1 is the continuity of the interventricular septum with the anterior wall of the aorta. That's important in excluding override abnormalities. The next thing I look at is I look at the size of the aorta in reference to the size of the heart. If the aorta is dilated, I consider tetralogy of Fallot, common arterial trunk, or double antler right ventricle. If the aorta is narrow or small, I think of coarctation of the aorta or interrupted aortic arch. The next thing I look at is the valve, and when I look at the valve, I expect to see the valve appear during diastole and disappear during ventricular systole. If it does not disappear and stays there, it's a feature of aortic stenosis. And I look to see whether the valve is thickened, and I will show you this in live scanning. So 1, continuity, 2, caliber, 3, the aortic valve. The next section, which is section 4, is looking at the right ventricular atrial tract. It is important when looking at the right ventricular atrial tract to look at the pulmonary valve. And when you are looking at the right ventricular atrial tract, you need to keep the free wall of the right ventricle in view, because otherwise you will miss the pulmonary valve. So when you look at the right ventricle being here, the left ventricle being here, when you sweep, you see that the pulmonary artery comes out like this. And if you keep the wall of the right ventricle in view, you can see it, then you will see the pulmonary valve. If you do not have the right ventricle in view, you run the risk of just seeing the main pulmonary artery, the right pulmonary artery, the aorta, and the SVC. If the pulmonary valve is back here, you will not see it unless you have the right ventricular wall in view. So one, you need to have the right ventricular wall in view to see the pulmonary valve. Two, you need to see that pulmonary artery is bigger than the aorta and is bigger than the SVC. Number three, when you look at the pulmonary artery, you look at the branch of the pulmonary artery that goes behind the aorta. You may also see the pulmonary artery dividing into the left main branch and the right main branch of the aorta and the SVC. Or you may see the pulmonary artery continuing straight as the ductus venosus with the aorta and the SVC. So you don't see the left branch and you don't see the right branch. So when looking at the pulmonary artery, you can see it in three different ways. This is important to understand, and I will show this in live scanning. When you are looking at the pulmonary valve, you also check to make sure that during ventricular systole that the valve disappears completely, and make sure that the valve is not thickened. And when you come to the last section of the heart, which is section number 5, is the three-vessel tracheal view. And what you're looking at this is the main pulmonary artery, which continues as the duct and then joins the aorta. This is referred to as the V sign, the trachea and the SVC. So when you look at the level of the main pulmonary artery and the duct and the aorta, they are equal in size, high in the chest at the level of the three-vessel tracheal view. When you look at these two vessels, you must see that these two vessels are on the left side of the trachea, not the right side. When you look at these vessels on colored Doppler, you need to make sure that there is laminar flow across both vessels. This view is an extremely important view. So if you say to me, Simon, you have shown me 5 sections, which sections do you think are the most important sections? And I will tell you the most important sections are the 4-chamber view of heart and the three-vessel tracheal view. And that's why in screening in the first trimester that we include the 4-chamber and the three-vessel tracheal view, because this gives us the highest detection rate. And if you suspect that there is a problem in the 4-chamber and three-vessel tracheal view, that's when you go ahead and then look at the 5-chamber, this section, and this section. So that is a summary of the SIêU guidelines for examining the heart. This is a very busy slide, and this slide is in Vietnamese in your handbook. But it tells you what are the problems that you can see in section 1, section 2, section 3, section 4, and section 5. And in my last talk, I will go through section by section, showing you abnormalities, these abnormalities that you will see. If you look at cardiac abnormalities, there are around 45 discrete cardiac abnormalities. And if you have in your mind, knowing what the problems are section by section, then you know what to expect to see. And if you know what to expect to see, you are more likely to see. So I want to share with you some golden rules in imaging which will make it easier for you to understand when you go to work tomorrow morning. The first rule is in every cardiac scan that I do is I look at the descending aorta. And the descending aorta will tell me where the left atrium is located. Because directly in front of the descending aorta, almost always, is the left atrium. That's very important because I don't need to look whether the vein is cephalic or breech or transverse. It doesn't matter. If I know that this is the descending aorta, I know that that's the right ventricle straight away. So if I see regurgitation here, I know it's tricuspid valve. Why? Because this is the descending aorta, this is the left atrium, this is the left ventricle, this is the right ventricle, this is the right atrium. So straight away, without knowing any position of the baby, I know the chambers of the heart. It's a very important and most important clue. The second important clue is that when looking with colour Doppler, you must always have your red up. So when you look at inflow, that inflow into the heart is red, and outflow coming out of the heart is blue. It's like driving a car. You will know that if every scan that you do, that outflow is blue. If you see red flow here, you know you have a left heart region. Or if you see red flow here, you know you have a right heart region. Let me explain, because this comes to the next rule. This is golden rule number 3. If you look at the vessel that's closest to the trachea, it's almost always greater than 99%. It's the transverse aorta. So this is the transverse aorta. This is the main pulmonary artery. That's extremely helpful. Then you say to me, Simon, sometimes the trachea is very hard to see. I will say, okay, then take the SVC as second best. That the vessel that's closest to the SVC will be the transverse aortic artery. So now I have given you 3 rules, and I want you to apply these rules. And I'm going to show you 2 video clips. And I want you to apply these 3 rules and tell me whether this baby has got a left heart lesion or right heart lesion, whether this baby has got a left heart lesion or right heart lesion. You say to me, Simon, you have not shown me the 4-chamber view of heart. How can I tell you? Because I've given you 3 rules. The first rule is, when you look at this case, that the vessel that's closest to the trachea is the transverse aortic arch. So that is the aorta. And this is the pulmonary artery. And I told you that red is always inflow and outflow is always blue. And the flow in the transverse aortic arch is red. So there is reversal of flow in the vessel closest to the trachea, which tells me that this is a left heart lesion. That this baby is going to require prostaglandins after birth, by that single image. If we look at the same principle on this baby, this is the trachea, the SVC, this is the aorta where there's forward flow, but on this vessel here, there's reversal of flow. This is obstruction on the right side of the heart. This is the baby who has a right heart obstruction who will need prostaglandins after birth. So the 5th section is an extremely important section because it allows you to determine whether you're looking at a right or left heart lesion. It allows you to determine if there is reversal of flow along the arterial duct, and it allows you to cancel patients appropriately whether they will need prostaglandins and whether they need to be delivered in a central referral centre. Golden rule number 4. It's very important when examining the baby's heart that you use the SIêU, because sometimes things are moving so fast it is hard to understand. And I show you an example of a cardiac abnormality. This is a 4-chamber view of the heart where the left ventricle is smaller when compared to the right ventricle, and the left atrium is smaller when compared to the right atrium. How do I know that this is the right ventricle? Because this is the descending aorta. So if that's the descending aorta, that's the left atrium and that's the left ventricle. So if I play the video clip on this, I then look at color Doppler and I see red, blue, because I'm experienced and I can see that there is bidirectional flow in the pulmonary veins. But if I really want to understand it, I slow it down. Red, blue. It is much easier for me to appreciate that this baby has got reversible flow in the pulmonary veins. And if I see reversible flow in the pulmonary veins, and I see that the left heart is small, this tells me that the foraminal valley is obstructed. And this is a serious cardiac lesion. A baby with a hypoplastic left heart with reversible flow in the pulmonary veins is going to crash after birth. But if I look at the spinning loop on slow motion, that I appreciate what I've seen is real. This is a baby with a hypoplastic left heart at 13 weeks of gestation that I showed you yesterday. It's only when you turn it down very slow, you see red, blue, red, blue with each contraction of the heart. So you get reversals of flow at 13 weeks of gestation in the pulmonary veins with the hypoplastic left heart. Golden rule number 5. When examining the heart, it's a good idea, and you saw from the live scanning yesterday that I did a lot of scanning with the split image when I'm looking at the heart. The advantage is that I'm able to see whether, one, that my settings are correct. When I looked at the left ventricle, I'm checking that the fill in the right ventricle, the fill is normal. But in this case, I'm trying to work out, using SIêU, as to where the regurgitant jet arises from. So here is red, and this is blue, so it tells me that it's tricuspid valve regurgitation. I know it's tricuspid valve because the aorta is here, left atrium, right ventricle, right atrium. I know it's blue because the inflow should be red, but I'm seeing a blue jet. And I'm splitting the image because I can see exactly what the valves look like at the same time as looking at the colored blood flow. I can tell that this baby has got tricuspid valve dysplasia, not Epstein's anomaly, because I can examine the color and 2D at exactly the same time. When I look at the valves, I can see that the valves are thick on the distal end of the valve, and I see the highest velocity is exactly at the point of where the valves close. I cannot see the valve close with color, but I can see the valves closing in 2D. And that's when I'm looking at valvular disease that I compare color and 2D side by side. Golden rule number 6. I show you a video clip and I ask you a question. Is this baby's heart normal? You say to me, Simon, you are showing me the right ventricular outflow tract, section number 3. I say yes. But is it a normal right? You say, yes, Simon, it's normal because the pulmonary artery is larger than the aorta, is larger than the SVC. But I say to you, can you see the pulmonary valve? And you say, no, Simon, I can't. And I say, why can you not see the pulmonary valve? Because you do not have the right ventricle in view. So if you look at the right ventricular outflow tract without the right ventricle in view, you will not see the pulmonary valve. This is why most babies with pulmonary stenosis, the diagnosis is missed prenatal. Because most people who examine the heart look at the 3-vessel view of this section and do not see the free wall of the right ventricle. And most babies who are examined in the 3rd trimester of pulmonary stenosis are simply missed. It is one of the most common missed congenital heart abnormalities. In the cardiac handbook, which is outside, you get your copy, I just show the importance of looking at the right ventricular outflow tract in all its branches, so you understand its branches, because there are abnormalities that occur in the branches of the pulmonary artery with the main pulmonary artery may be normal, such as Addis syndrome. Golden rule number 8. When you're examining a heart and you're training out as a doctor, at the beginning of your training, it's very important to take a 4-chamber view of the heart, to take a split image and demonstrate the right ventricular outflow tract. Why? Because you understand the spatial relationship that the artery that comes out of the right ventricle sweeps to the left. It's what's called left convexity. So left convexity is normal. This convexity is normal. But if you sweep from a 4-chamber to 3 vessels, and the vessel comes out like this, comes out of the right ventricle, then you are looking at transposition of the great arteries, or transposed great arteries in double outlet right ventricle with subpulmonary VASD. So it's very important to understand in screening the heart examination that you know the direction the pulmonary artery comes out of the heart. So this shows you the left descending aorta, left atrium, left ventricle, right ventricle. And as we look at the convexity of the pulmonary artery coming out of the right ventricle, it's normal. The aorta and SVC. But if you see it looks like this coming out of the right ventricle, this is a baby with TGA, this is a baby that's normal. So it's important to understand that relationship. The next is an important rule number 9. When you're examining a baby in the first trimester of pregnancy, you need to set your PRF at 25 to 35 centimeters a second, like yesterday. When you're scanning in the second trimester, you need to set at 45 to 65. And in the third trimester, you set at 65 to 85 centimeters. So you need to get your PRF settings correct for every examination that you're performing. Again, this detail is in the handbook. When you were looking at inflow, you set the red on top. So you see these 3 vessels of field view, and you demonstrate the inflow into the ventricles. This is a first trimester scan. If you want to see the pulmonary veins in the first trimester, then you reduce your PRF to 18 centimeters a second. Now you can see the branch pulmonary artery, right pulmonary artery, left pulmonary artery, but also you can see the other tiny branches of the pulmonary artery. So if you look here, this is the right pulmonary artery giving off tiny branches. These are the pulmonary veins coming in here. Because my PRF is set at 18, so depending what I'm looking at the heart will depend on my settings. You have a choice when you're using color to use color Doppler, power Doppler, and slow flow Doppler. You can only control your PRF with color and power. You have no control on PRF with slow flow. The second thing which I will show live scanning is when you are looking in the second trimester. I use power as number 1 for me in the first trimester, and color is number 1 in the second trimester. But you can try all technologies. When I'm looking at the second trimester, I set my PRF at 45 to 65. I then also have the option of using the newer technologies of graphics flow, where I can see the ventricular fill in the right and left ventricle, ventricular fill in the right and left atrium. If I want to look at the pulmonary veins, I drop my PRF to 15 centimeters a second. And then I reduce my balance. So I have a higher gray setting. And now I can see my pulmonary veins much more clearly. So this is a combination of using power Doppler and color Doppler with balance. And I'll show you this control. But it gives you beautiful definition of the tricuspid valve, the mitral valve, the atrium primum, and the pulmonary veins. So, in your color, a very important rule, number 10, is set your PRF first, set your output second, keeping your mechanical and thermal index less than 1, and select your gain, number 3. Rule number 11, when you are scanning a baby, you need to know what is the velocity of flow in the vessels that you're imaging. So that's how you choose to set your PRF. For every week that goes by, the velocity of blood flow increases in the baby in the different vessels. And if you look at a baby, we scan to look at the anatomy between 20 to 25 weeks, it is always less than 100. So I talk about the rule of 100 at the mid-trimester. If you ever have velocities more than 100 in any vessel in the baby at the mid-trimester, you are going to be looking at an obstructed heart region of some sort. So you go to work tomorrow morning in Hanoi, you scan a baby, and you look at the velocity, you see that there is increased color on the left ventricular outflow tract, and the valve looks a little bit thickened. And you say, Simon, I think this baby's got aortic stenosis. What do you think I will ask you to do? I will ask you to put a pulse Doppler gauge after the valve. There's the valve. I'll ask you to put the pulse Doppler gauge after the valve. And then you see my velocities are greater than 100. So I know my 100 rule is broken. I know that these babies' velocities are around 120 centimeters a second. And you say to me, Simon, but sometimes when you do Doppler, you get false positive readings. I say, I agree with you. But how can you be sure that this baby's got aortic stenosis? The answer is, you look at the pulmonary artery and you compare. Because the velocity of flow in the pulmonary artery and the aorta, the baby are the same, more or less. And when you look at the flow in the pulmonary artery, you see this complex, this black in the center is laminar, where this is hyperechoic throughout. This is a stenotic lesion, this is laminar flow, and the velocities are 45 centimeters a second. 45 to 65 centimeters a second. This is normal pulmonary artery, this is a stenotic lesion. And now I am confident, because I am comparing the aorta with the main pulmonary artery, jumping the Doppler gauge from one vessel to the other. I now have certainty. And also, which is very subtle, and if you are an experienced operator, you will realize that the rate of rise is slow in vagal stenosis. Whereas if you've got normal, your rate of rise is straight up. So a normal blood vessel will have an immediate rise and a fall. Whereas a baby with smaller blood vessels will have a lollipop rise, like a lollipop. Slow rise to peak, slow descent. That's normal, and that's stenotic. So when you look at this waveform, this is rapid rise to peak systolic velocity. This is a slow rise to peak systolic velocity. It's a subtle finding, but it's also helpful. Golden rule number 13. Always go the highest frequency transducer, starting off at C1 to 6, moving up to a linear 15. This is a baby that shows you different frequencies and how much E. This is a baby at a lower frequency at RAB6. Yeah, RAB6 with a bilateral SVC. So I told you when we did our first rule of thumb is look at the three vessels to field view, and you should see the main pulmonary artery and the aorta. You know that the vessel closest to the trachea is the aorta. But you are seeing not three vessels, you are seeing 1, 2, 3, 4. This is a baby where this is the extra vessel that's sitting beside the pulmonary artery. There should be no vessel beside the pulmonary artery, ever. So this is a baby with a persistent left superior venous vena. But I know it's the pulmonary artery because that's the trachea. And I know there's laminar flow, there's no reversal flow. That's applying different rules. Golden rule number 14. Do a split image and demonstrate that the stomach and the heart are on the same side. 2/3 of the heart is in the left hemithorax and 1/3 is in the right hemithorax. It's important to do this so you do not miss heterotaxy syndromes. I'll skip number 15. Skip number 15. And when looking at the heart, the descending aorta, left atrium, left ventricle, right atrium, you should never get mitral valve regurgitation. If you ever see mitral valve regurgitation, it means that there is a problem in almost 100% of cases. Whereas tricuspid valve regurgitation is common. 5% of pregnancies will present with tricuspid valve regurgitation. 99% of pregnancies you will find that mitral regurgitation is associated with abnormality. Here's a baby with mitral valve regurgitation who's got critical aortic stenosis with a hypoplastic left heart. When looking at the absence of plate and artery, the idea is not to have the spine posterior, but have the spine on the side. And it's in that position, then you will see the absence of plate and artery going behind the aorta and the SVC. So this is a baby here. If you look, this is the trachea, SVC, that's the aorta, that's the main pulmonary artery, and then behind the trachea is right subclavian artery. But I know that this is the right side because that's the trachea, I know that's the aorta, I know that that's the main pulmonary artery. Again, without looking at the four chambers of the heart. And the baby also has a muscular ventricular receptor defect. So it has an aberrant subclavian artery and a mid-muscular ventricular receptor defect. Slow flow is a very powerful tool that I use mostly in the first trimester of pregnancy. It is also a very valuable tool in the second trimester. In this baby, I cannot see that there is an aberrant subclavian artery. I can see it on 2D, but when I look on Doppler, I cannot get filled. Why? Because the vessel is perpendicular to the ultrasound beam. So for slow flow, it doesn't matter if it's perpendicular, because with slow flow, you will get filled. It doesn't matter the position the baby's in. And that's why I like slow flow so much, because it's not dependent on the angle of insination. And now you can see the trachea, transverse aorta, pulmonary artery, and you can see the vessel running behind the trachea is an aberrant subclavian. When you were looking at golden room, the second last rule of golden room number 19, this is a very good view for picking up defects in the septum, picking up AV canal defects. So when looking at AV canal, it's a much better way to look at the apex of the heart pointing upwards than putting on the heart in a transverse position. That's very important for imaging. The second rule is if you want to get a short axis view, if you want to work out whether it's a complete AV canal defect or whether it's a partial atrial ventricular septum defect, you cannot tell with the baby in this position. You have to make the apex of the heart at 3 o'clock and 9 o'clock and then rotate your transducer. So in this case here, the heart is on its side, and if I want to see whether it's an AVSD, I then rotate and I see the tricuspid valve and the mitral valve. And I can see the septum is intact, that this is normal. But when I look at this baby, I can see that there is a common AV valve defect. And the only way I can get this view in is if the baby is lying on its side and then I rotate the transducer. But in the standard views, if I want to see a VSD, then this is the best view. So this is the best view for seeing a VSD, and you can see some AVSDs, but this is the best view for working out whether it's partial or complete AVSD. Okay, that's it. I might go to the live scanning now, and then let's put those rules to the test. You can bring the patient in, and we'll start the live scanning. This shows you a baby here, using a 22 weeks of gestation, using slow flow technology, and I'm here looking at the pulmonary veins. I then use cine loop. I drop the cine loop until it's very slow. And once I see one pulmonary vein entering into the left atrium, I've excluded total anomalous pulmonary venous return. This is one of the most commonly missed major congenital heart defects. Also, when I look at slow flow of this baby that I just saw a few days ago, you will see it's also very nice technology for picking up multiple VSDs. So when I look at this, I can see there are multiple points where I can get Doppler flow using slow flow. But with color Doppler, this can be very difficult, and also with power Doppler, this can be extremely difficult. So in summary, we look at the evaluation of the heart, looking at the first section, second section, third section, fourth section, and the fifth section. And if you systematically look at this with both 2D and with color, you will pick up the majority of major cardiac abnormalities. And this is an important picture that is in the cardiac handbook because it shows you what are the abnormalities that you will see for each section. And I will come back in my next, are we good to go? Yep, patient is just getting on the couch. And when I come back after the live scan, I will walk you through the abnormalities that we see on each section. Starting off with the first section. Stomach on the left, aorta on the left, IVC anterior on the right, intraperitoneal curve to the right, and gallbladder normal. Okay. And USB.
Vâng, sau đây chúng ta sẽ đến phần thực hành siêu âm trực tiếp trên bệnh nhân của thầy. Bệnh nhân đầu tiên